아, 이틀에 대한 전달 갈 거야? 휴가를? ES를 맞아서? 난곧 전주에 가고 그 다음 주에 또 ESC 가고 그 다음 주에 또 인도네시아 좋네. 이해해 줘. 생각보다 그렇게 일찍 끝났던데? 어제는 점세가 그래서 이 정도 네. Thank you for coming to ECG conference. My name is 동서. Pagma, can you tell me about this PG? Loud.
Normal sinus rate, heart rate almost 180 BPM, and QRS duration 0.
Almost over 160.
Yeah.
Okay.
And axis is superior axis, and RBB morphology. And B5 and 6 S wave, deeper S wave than R wave. And in the B1, RBB morphologies, first R is shorter than second R. And ABL Q wave is, I think, BT. It's the good idea.
So which finding favors the BT and which finding favors S-weak aberration?
B5 and B6 deep S wave, and B1 RBB morphology, if there is BTBW conduction, first R wave is taller than second R wave. RBB morphology is different.
How about B2?
B2.
I agree with your opinion, it's BT, but we need to read the ECG systematically. So, for example, whether you see the AB dissociation, fusion beat, capture beat, okay? Those are the very decisive criteria for BT diagnosis. And then unless there's a AB dissociation or fusion beat or capture beat, then you can move to the highly suggestive BT finding, such as you told the atypical RBB morphology, EVAS waving 356, positive or negative concordance, and the linear axis, the no man's land, northwest axis, something like that. So, Haguma, what do you think? Which finding did you see in this wide charismatic ECG? Go. It's time. Speak louder. Slowly, please.
Monomorphic pattern and basically the PPD pattern and positive QRS and all precordional leads and also defects in B6 and I take 1 and ABF and 2 is not worth physics and Also, initial outweighed ABR such as BT, and no AD association, and no capture beat, no fusion beats. Beat 3 and ABR show a little bit more QS complex. So it looks like BT.
ET. So what kind of ET? Haguma code is like the vascular VT. Can you differentiate from pleuris VT?
Very nice BT. I was noting should be seen in 1, 2, 3. And also, ASIS is about what is this? It against the battery muscle.
Northwest axis is hypermost, hypermost we say VT. Anybody read that kind of criteria textbook? I never read about that. Northwest axis favors the VT. It's no matter what. Okay, let's listen to Junyoung's thoughts.
I agreed with its VT, and I think this notch is not on the every bit, and I think this is evidence of AV dissociation because rate is so similar with sinus node. It's regular. And also axis is northwest, so I think this is VT. And thinking about the origin, the initial deflection is very fast. So, and the RBB pattern. So I think this is the coming from the conduction systems. So vascular VT, so my opinion.
Okay, Junyoung told a very important point. If you look at the bottom rhythm strip lead to class morphology changing bit by bit, right? And for example, this kind and this kind different, right? That is potentially VT, maybe dissociation. Okay, so you need to carefully watch for the cross morphology, and especially ST P wave morphology. If there's some notch, that could be a P wave. Okay, but if it is really vascular VT, most of vascular VT patients are young and very good VA conduction. The some patient with the vascular VT shows 120 VA conduction. Okay, so at that time you can ask the VA dissociation. Okay. Okay, and any other special finding? How about B2 and 3? Is it usual?
I don't know what is meant by usual, unusual, but I think that this KG is more consistent with uploading rather than a secular VT. That is good. ABR and V1, I think Paris is not that narrow. And As you mentioned, there is, I think there's a very minimal link at the start of QRS and V1. So I think this is completely rather than insecure. But we cannot.
Dr. Joe, how do you think why there is some fractionation in B2 and 3? There's also reports, even our center, there was report, fractioning the choice, like epsilon wave or other the fractionation at the end of a choice is high risk of sudden death. Okay. But if it is really vascular BT, the risk of sudden death is very low. So we need to think about why there is fracturing. So let's think about the mechanism. What is the mechanism of choice widening and fractionation? So why fractionation mechanism, mechanism of fractionation and choice widening? That's not I think that mechanism may be to play very- The choice with this reflects the ventricular depolarization time difference, right? If there's bundle branch block, the role of conduction system is spread out the depolarization wave of all of the ventricles simultaneously, as much as it can. Okay. So if QRS is really wide, the reason is ventricular total depolarization time is long, and the depolarization dispersion. Okay, and the QRS, the fractionation means there's some zigzag conduction or abnormal conduction, delay or conduction block area inside the ventricle. So probably even though it is, I don't know, it is vascular VT or the Kaplan's VT, we need both. But regardless of the diagnosis, the patient has some conduction system disorder. That's why there is a fractionation wave in B2 and 3. Okay, let's both. Vascular VT, pleuros VT. Okay, 1 to 4. Please let us know the outcome.
Actually, see, okay. This case is 70-year-old male, and his chief complaint was palpitation with chest discomfort. Past medical history included congenital megacolon, and the patient felt sudden palpitation on the way home from school. He went to a local ER and was found to have VT. DC cardioversion was done. He came to our hospital's outpatient clinic. Vital sign, I could not find a vital sign record from the other hospital, but considering the condition and the treatment done in ER, he may be unstable, and lab was normal. This is the ECG strip during the DC cardioversion. And sinus rhythm was achieved successfully. This is the first ECG done in our hospital. His chest X-ray was normal. Echo showed no abnormality. This is the ECG from August, and actually he was admitted to get VT ablation. And since March,
why silence ECG treatment like that? Did he take some medication?
Yes,
What kind of medication?
he had verapamil.
I'm not sure if Parapam make this kind of J wave. These are J wave, right? Okay. Did they have the history of syncope or families of sudden cardiac death?
No,
Especially in young patients, we need to check out whether he has some family history. Yeah, or
since March he took verapamil, and actually yesterday VT ablation was done. It was fascicular VT, left posterior fascicle type, and successful ablation was done.
that's it.
Yeah, that's it.
It's simple. But still, I have curiosity why there is some J wave and fractionated torus. Any comments? Professor Yu? You should check the genetic testing, it's kind of young and arrogant. Talking to based on for the professor, they will always insist you should check every patient, cardiomyopathy and young generation arrhythmia. You should check it in GS. I think that's reasonable. Dr. Chan Huang also wants to have a blood test, genetic test for the patient with vascular VT, especially Myanmar patients. Yeah, because there's so many vascular VT. I think you guys already heard about the discussion with me and Dr. Huang. I discussed with Mark Linsky and Dr. Nogami, and whenever he visit Southeast Asia and especially India, there's so many vascular VT patients, and unusually easily inducible, and a very good response to the VT ablation. But in Caucasian and Western countries, it's very, very rare. So we need to think about the potential pathophysiology of a genetic background. Also, some hidden myocarditis. Southeast Asian area and India, there's many the subclinical myocarditis. The inflammatory change makes some conduction block, and the subclinical myocardial disease. That's those factors the patient vulnerable to vascular VT induction. Okay, any other comment? Yeah, please. In the ET report. Is there a role for pacemaker vascular VT matched on 94%? You mean during mapping? This is ECG conference. Okay, so that's a good question. I cast the same question to the Delano. He described the vascular VT first time. When he worked in the United States, but he went back to Taiwan. I asked exactly the same question when I was your age, and his answer was, of course, the vascular VT ablation pace mapping sometimes doesn't match, but still pace mapping is very important. That was his answer. Okay. Matching is more weird. Why? Because you should pace exactly the exercise of lower turnaround to get the exact match. But this high matching such as that, he paced that the lower turnaround. We don't know. Yeah, in the textbook, there's a description. So exit site of a vascular VT is different to the re-entrant circuit, right? That's why the pacemaker doesn't match. But if you pace not the myocardium, but the exact vascular point, probably can make a good match. So I don't believe the 100% piece mapping match is mandated to run vascular VT, but still it is like up to you. How's your experience?
Yeah. Yesterday, I also upgraded one vascular VT.
Yesterday,
Right, so pacemaking goes only about 89 something. That's good. And when I ablate the posterior vascular proportion of the axis side was changed to the lower position. That's the axial position. So I make the two different side of ablation reason after the more apical. I think so. I think the ability was originates from underneath patellar muscle, the side. So I blocked the main axis side and changed apical this way. So after I burned the apex position,
so it could be performances.
yeah, it was very sensitive, and I checked the when it was used. I checked the treatment in another position before fusion. So I think it was mainly the reentry gene, but you about the combined popularity.
That's common pain, right? Yeah, circulation. Vascular VT could coexist with papillary muscle entry because papillary muscle is pillar structure. So around papillary muscle is reentry. Okay. It's nice ECG. And lastly, we have 5 more minutes. Dr. Joe, could you summarize about the J-wave syndrome? Unexpected question. Yeah, that is definitely common J-wave. Okay. J-wave syndrome is another other groups tell it as early repolation syndrome. I heard that Dr. Scheduled another case of early repolation syndrome in September. And it is repolation abnormality, but the Rugada insists that it is the mechanism of depolarization abnormality. There's two different groups. One group insisted early repolarization syndrome and J-wave syndrome is a repolarization abnormality. That is Ansel of this group as a basic scientist. And the Brugada group is a electrophysiologist, very aggressive, invasive electrophysiologist. They believe J-wave is produced by depolarization anomaly. In some area, depolarization very delayed. So I think both the mechanism is reasonable, but it is hard to prove in human. Angelovich said that the theory hypothesis is there's transmural reentry because their action potential duration and endocardium and epicardium different, and medial myocardium is longest action potential duration. So that's why in some patients, genetic background and repolarization dispersion, transmural dispersion make reentry and vulnerable to sudden cardiac death. And another one is theory hypothesis. In some area, they prove it by the cardiac mapping. In some area, it's delayed activation, generated this kind of J wave. And that's why it is delayed activation, means the substrate for VN3 later, sudden death and BT. Okay? And what is proper medication? If the patient with this kind of ECG, they suffer from recurrent syncope. And we can approve the VT or VN. What kind of medication can you consider? Oh. You don't know. You're looking for one. You asked to check GPT? So in those patients, you should not get prescribed beta blocker. Sometimes beta blocker aggravate the risk of sudden death. And generally, even though the profile is very limited, Canadian work. Okay. Okay, so this is Saturday. Please look for regarding the J-wave syndrome and vascular BT this afternoon. Okay. Okay, let's go ahead. Finish. Okay, thank you very much. Cases.
네.
J-wave 도 한번